It's interesting that what you mentioned, even that may not be happening. I mean, how many women were sent for calcium score, because they had a mom who died, at the age of 58, right? So even those things at the basic, like how many people are consistently screened for diabetes, right? Because as you transition through menopause, one of the things that happen is because of all those abdominal metabolic changes, you're more prone to diabetes, or if your diabetes that you already have, it gets worse. So how many people are trained to realize that in that transition, all those things metabolically changes, that honestly, they like, why do you even care about this stuff? Because it all affects how long you live and how you live.
Have you made it past menopause, or are you going through it now? I'm Dr. Pat McShane, and on the Women's Healthspan Voices podcast, I'll guide you through the menopausal transition and beyond, helping you to thrive in this powerful time of your womanhood. Hello and welcome to Women's Healthspan Voices. I'm Dr. Pat McShane, and today I have a very special guest with me, Dr. Hanah Polotsky. She is trained as an endocrinologist and has had roles as physician executive in a number of different organizations and some quite specific training in performance and other kinds of issues that are relevant to our discussion today. So good to have you with us, Dr. Hanah. Welcome. And in your current clinical practice, you have fashioned a practice with women physicians, executives, and professionals going through and having gone through their menopausal transition. And I suspect that you kind of came across that role in sort of how I came across this podcast, which is finding that there was a gap in the treatment of women and the information that was available for women going through menopause for one thing and then into the full menopause condition. So maybe you could comment a little bit about what drew you into that realm of practice.
Yeah, I think a lot of times what draws us into what we end up doing is probably what's happening to us and around us. And I did not expect myself as I was going through the perimenopause and menopause transition, how much is going to affect you and your performance as an executive and as a doctor and as a mom, as a wife. And I realized that the same things that patients complain about, the brain fog, I'm not as sharp, I'm not this. And when it starts happening to you, you start asking questions why. And obviously you start digging deep to fix it. And I think that fascination with that's ended up sort of completely changing my career path, because I made the decision that I probably can give back more by helping women optimize their performance. And that started with me and my friends who were in the higher level roles. And I think giving this back to the world, sort of this ability to not struggle through perimenopause and menopause, but actually strive and use it as an opportunity to pivot and know that you can achieve so much more. It's not a decline. It's actually the time for you to grow and excel and just be different you.
So you, in our prior communications, you mentioned that you think that professional women actually are more likely to kind of suffer, I use that word broadly, from the issues that happen to most of us as we transition through menopause. And tell us a little bit more about why that might be, or the kinds of issues that come up for professional women in this transition time.
I think if you're working always at the highest level, you have to be at the meetings, you need to appear to be sharp, you need to look great, all these extra requirements that women are required to perform. And then suddenly you may not be sleeping as well, or you're noticing, and we know it's been studied that there are some problems that are temporary, but they are problems with memory and concentration and sort of how fast you're thinking on the spot. And you're so in tune at performance on the highest level that you start noticing that, even if other people may not notice, but you do. And I think it has to do with probably also the women who get into those roles, or the women who get into medicine, or the women who succeed because you're running the family on the side. You're running two jobs the whole time. So you're a high performer, and therefore your requirements for you are much higher. And as soon as you start minor decline or your perceived minor decline, you're becoming very hard on yourself. And I think that's exacerbates the stress, and exacerbates some other things, like obviously in perimenopause, we start redistributing weight, right? It becomes more abdominal and the sleep starts becoming a problem. And so it's kind of a collusion of multiple factors. But for somebody who is performing the highest level and they don't have a break, right? They just work in 7 to 7. I mean, if you work in those executive roles or if you're a doctor currently in our healthcare system, you may be working 8 to 5, but all this extra in basket and extra work or extra other things, I mean, you don't have a break. So throw into that the fact that you have some cognitive, even though it's minor decline, right? Or something perceived, or inability to, you wake up at 3 o'clock in the morning for no reason, and suddenly your sleep is disrupted, and then the hormones start colliding. I think it's because you're working on such a high level and you don't have a break, you don't have a time to rest. And I think
Mhm.
this is why you're becoming more affected. And because you have those high expectations for yourself, it's almost you become your own enemy because you have such a high expectations.
Your own worst critic. Yeah. Yeah. And many women at that stage in life, at our stage in life, are dealing with aging parents as well as children who are going through multiple transitions, and so on. And your experience when women go to their healthcare practitioners, their physicians or PAs or NPs with issues, they may be dismissed or told that it's not really going on. Tell us a little bit more about that in your
I
experience.
think it's a common sort of thing in medicine that when the labs are normal, a lot of
Mhm.
time we jump to conclusion everything else is normal. And it's not just menopause. I mean, I can give you 100 different conditions. How many women with a thyroid dysfunction, their labs are normal, but we know now that 20-30% of them are actually not functioning and they do have brain fog, and we're not supplementing them the way we probably need to supplement them. So this normal is not normal. And I think that's probably one of the hardest thing is for the doctors to step back, who, again, I don't blame the doctors when you have 15 minutes and you have pressures to address, especially in primary care, multiple things all at the same time, and you want to get preventative stuff done, and you want to do this and this, and stepping back and saying, wait, what is actually troubling them? What is actually driving this? And kind of look outside of normal and say, what is normal anyway? Because, just because your labs are normal, that doesn't mean that you're performing, right? And I think most of the complex things in medicine are not identifiable on labs. And I think that's where the other problem is that the women come to you and say, but why can't you just test all the hormones? But Pat, you and I know that unfortunately, as you go through the perimenopause, the problem is not that your hormones are low, hormones are high. They're fluctuating like crazy. And you doing whatever hormone test at that moment, outside of making sure that other hormones are intact, like thyroid and other things, it's not helpful. So that if we cannot identify the normal of normal, then how do we actually help the women? And I think sometimes, and again, I've done that. I'm sure you've done that. Where, like, when things are normal, it's when you start going through this yourself. It's like when you're a pediatrician and you don't have kids and you tell your patient, please don't sleep with your kid, and don't keep the infant in your bed. And then you become a mom and you're like, oh my gosh, I'm so exhausted. I'm going to let them, So I mean, I think that's actually going through that transition yourself and realizing that, hey, patients are not wrong. They're just not always able to articulate what's not normal. And then you
Mhm.
cannot rely on the labs to
Mhm.
tell them. And at the
Mhm.
end of the day, I always tell patients, not just for in the perimenopause, but all these complex conditions, like say you're in a chronic pain, or we cannot explain your symptoms, or there's a lot of conditions like that. We are limited in medicine how much we know. And I always ask them, do you want a label or do you want to be better? And I can help you to be better because there's a lot of ways to make you feel better. I cannot always label you or give you, say, hey, this hormone is dysfunctional or this lab is out of line. But I can work with you and look at you as a whole human with your life and all the interactions in life and how the life influences how hormones interplay, how your diet interplays with that. I mean, we're so complex, how your gut microbiome may be influencing this and so many other things, and kind of build a path for you with you to make you feel better and optimize you versus label you. But so that to me is, yes, that's the problem. I say the fault of normal. And we a
Hmm.
lot of times will fall into this kind of trap of normal. That normal is not normal.
Yes, and we may or may not be measuring the right things. We think that we're doing a comprehensive look at an individual's physiology or what's wrong with them, but in fact, as time marches on, we keep learning that there's more complexity to, heart disease or arthritis, joint pains,
Every
et cetera, than we thought, 5 years ago or 25 years ago, certainly when many of us trained. And there's been so little research on the menopause transition per se, and then into the menopausal years, how women's physiology differs. We have different diseases that we experience, and we experience the same diseases differently than men. So a lot of things that need to be made up here that hopefully we're starting to do some of that work. So in your experience, what are the main things that you would advise a woman to either do or stop doing to kind of mitigate as much as possible with her normal lab work, the symptoms that she's having?
I mean, honestly, first it's you start by understanding what driving the symptoms, and also understanding that it's not one thing. It's probably three, four different things. And therefore, the treatment that you're going to come up with is going to be very much individualized. You're also trying to understand genetics, what happened to your parents, grandparents, not just when it comes to sort of menopause transition, but it's actually that and all of the other metabolic parameters. Because perimenopause and menopause is really huge, not just hormonal change, but the metabolic change. And I think a lot of this plays into each other. And then you add to that the stressors, as you mentioned. Like as we speak, I have one kid who's getting married, another one is having a baby. And my mom developed dementia and she's like a fourth parent with dementia. And it's like learning to, first of all, understand how all of those things, not just, metabolic stuff. And like I personally have diabetes, and horrendous cholesterol genetically. So it's all plays into this. And I think one of the biggest things I've realized in the transition was we're so used to saying, you eat less, you exercise more, and you're going to be great. And then a lot of women would see very soon at that age is actually a lot of times when you cut the calories and you just exercise more, you actually may not do well. So that was to me a big eye opener uh, to see that hey, it's actually what you're eating. It's maximizing the protein. It's how you're exercising. Introducing more resistance training, not just aerobic exercise. It's also learning things about mindfulness. One of the biggest things I personally realized that I didn't realize my triggers and how it's going to influence my body reaction. Also, you may need to think through basic things, recreational smoking. What you could tolerate before, you're not going to tolerate. You're going to get the brain fog next day. You know,
Alcohol.
alcohol, one glass at night. Oh, maybe. So like all of those things that worked before the 30s, suddenly they don't work anymore. And any minor change, both in what you eat, like high sugar intake, like simple sugars, right? For some people, triggers could be high dairy intake. So it all depends because what other things are happening. And then you make those changes based on one real patient at a time and not just what the books are saying, especially as you just mentioned. The books actually studied men, not women.
Yeah.
So if you actually look even into cardiovascular conditions or any conditions, there are very few studies that had women in them or proportion of women were smaller. So how we react to all those different things is very different than men. We're not little men. We're completely different with a whole set of hormones and other things.
And our medical care system is designed basically to say, oh, you have high cholesterol and some coronary calcium, go see a cardiologist. Your blood sugar is rising a little bit, your hemoglobin A1C is elevated, go see a diabetologist, an endocrinologist, so the
Yeah.
compartmentalization. And then pretty soon somebody's on 5 medications, side effects, none of them is working quite right, and maybe no one has really looked at some of the more fundamental underlying causes such as you've been
You,
mentioning.
it's interesting that what you mentioned, even that may not be happening. I mean, how many people, women were sent for calcium score, because they had a mom who died, at the age of 58, right? So even those things that basic, like how many people are consistently screened for diabetes, right? Because as you transition through menopause, one of the things that happen is because of all those abdominal metabolic changes, you're more prone to diabetes, or if your diabetes that you already have, it gets worse. So how many people are trained to realize that in that transition, all those things metabolically changes, that honestly, they like, why do you even care about this stuff? Because it all affects how long you live and how you live. And if
And
we, this is,
bone density is another one that we should be probably checking 10 years earlier when we can really do something rather than finding it when someone's 60 years old and they're already severely osteopenic and at risk for fractures. Yeah.
yeah, and and vitamin D and vitamin B12 in patients who are taking metformin for PCOS and there's so many aspects of just basic medicine that we could do to optimize people. And I think even that is not happening
Mhm.
because again, we're looking at people in a box and not as these complex humans that interact with a super complicated environment as well.
And in a 15-minute appointment and your primary care has changed or your insurance has changed, and so you can't use that primary care physician any longer. So it's tricky. And one thing I say on a frequent basis on these podcasts is if you're not happy with the answers that you're getting from your care providers, get another opinion. Basically, reach out and don't allow yourself to be dismissed. And it's tough because again, our insurance system, but once you hit 65, at least you have Medicare and you're
But even as Medicare will know, Medicare subsidizes procedures. Medicare
yes,
does not subsidize. By I mean subsidize, who do we pay for? Which doctors do we pay for? Is not the doctors who keep you healthy, right?
yes,
It's in by the time you need a knee replacement, and by the time you need a stent, the system failed because
yes,
all of this is most of it, I would say, is
preventable.
preventable.
Yes.
And most people don't even realize that most of the cancers we see in patients, are also preventable through a lot of the basic things. But the basic things are not so easy to achieve.
Yeah. One thing you mentioned meals, what you eat and when you eat is important. Sleep consistency is important, and that can be so difficult, especially if you're dealing with a partner or a spouse with medical issues or a child with needs or grandchildren support, et cetera. So it can be
And yeah, and I was just going to mention, I think the huge aspect is sort of the psychological as well as sort of stressors that exist. And I think the reason why I work with women who have to perform on the highest level is they are surrounded with a tremendous amounts of stressors. And I think that most of us don't even realize that we may not be perceiving stress. Like some people feel anxiety or some people feel depressed, but some people may not feel sort of those symptoms, but they actually, the body is reacting. And this is why they're having a brain fog, possibly. Or this is probably why they may be waking up at 3 o'clock. I'm not saying it's all psychological, it's actually not. But we do know that as you transition through menopause, if you're predisposed to depression or anxiety, it gets exacerbated. So, and the hot flashes go into this whole thing and how it relates to stressors around you and to sleep and to food so you can't just tackle one thing. You really have to untangle and create the support system, psychological support system, medication support system, exercise support system, diet support system, mindfulness-based stress reduction, and all those things that could possibly come in. And again, the exercise, what type of exercise? In addition to everything I mentioned, how are you going to make sure that you don't fall when you're 60,
yeah.
and that's contribute to fractures. So I think we have tons of amazing opportunities to use this time to pivot and make these women stronger, smarter, more capable, and it could be the prime of your life and not the decline.
You talk from a systems performance perspective about coming up with a plan, and what you just outlined sounded to me a lot like a plan. And tell us a little bit more about how you would go about doing that with a woman, because obviously you can't sit in a 15-minute appointment and go through, exercise, diet, social support, et cetera, et cetera. How do you do that bit by bit with a woman?
I think some of this is also using the right questionnaires beforehand. I think
Mm-hmm.
it's getting the right data. So the framework that I use that I actually published in my book that was more on physician leadership, it's called Guides, and it's based on a scientific method. And it's like you gather the information, you understand what's happening, you identify the root causes, and you build the plan to execute, and then you iterate the plan. So apply the same thing to the patient. This is why if you send all the right things to first identify what is the background, what is the genetics, what are we looking at, what happened before, what prior conditions happened before, what medications are they taking, what supplements are they taking. So you kind of gather all this info. A lot of times, if you have it beforehand and you can quickly sort of start seeing patterns before you even see the patient, then you can actually dive in with the patient in whatever time you have with the patient. And hopefully have more time than less time to start kind of double checking what they mentioned, understanding what is truly happening, and also sort of working together to identify the causes. Because I always said to the residents that I used to train, when everything failed, as the patient, they will give you the diagnosis.
Yeah.
Don't make assumptions that you know. And I think one of the differences that I've learned over time is you co-design care. So you don't tell them what to do because they're not never going to come in and do it. But that's where the motivational interviewing comes in. This is when people come up with the answers, and it's not you, the doctor, comes up with the answers. They're going to be likely to implement those answers, and also understanding how the habits are forming. Like you can't ask people to do 20 things. And you know that if they are committing to something, especially if they are committing in writing to you to one thing, and you give them 2 weeks or 3 weeks or a month, they are likely to follow that than when you're trying to say, oh my gosh, you're so wrong. You should quit smoking and quit drinking. And you do this and you do this and forget about this, and don't do that. Like, that's never going to happen. We don't function like this. And even the most sophisticated women, who are super great and they used to exercise and do things, if anything, the more you push on them, the likelier they're going to be more stressed and it's going to backfire. So
Uh-huh.
co-designing this plan to fit into the reality, right? So if somebody, again, being culturally sensitive, right? If they are certain cultures and they eat certain foods, how do you influence them in the family to understand that maybe that is not helpful in the menopause transition? And I have I'm from Belarus, and I can tell you if you eat the typical Russian foods, you're going to have more hot flashes. And so you
Interesting.
really have to, you have to rethink, like it's bread and sweet stuff and other stuff, high in saturated fat. So you have to step back and say, we know that the closer you eat to the sort of Mediterranean diet, plant-based diet, green Mediterranean. That is all those things where your food comes from clean sources of fruits and vegetables, and then good sources of protein with some carbs in, like high fiber carbs, like, brown rice versus white rice. Like those things will actually help you with hot flashes, and if your hot flashes are better, you're probably going to have less brain fog. And this is
Mhm.
just one aspect of the diet, right? So, designing what's possible within the framework of that patient. Not my framework, not your framework, Pat. What is their framework? What is their environment? What can they possibly do? And another big sort of thing that I've noticed over the years in my experience, don't make assumptions. I had patients who you look at and you're like, they will never follow this. And they're the ones who follow it. And
Mhm.
then you have patients who look super educated and super sophisticated and they understand everything and give you all the right answers, cannot follow one thing. So really, like, don't make assumptions and not what you think. It's really diving in. And this is why that framework, it's like a scientific method, right? You build the hypothesis with them, you co-design the plan, But until you test it, you do not know what's going to happen. And so
Hmm.
you test it and it backfires, you go back and reevaluate. Obviously, we get the right labs, right? Also, meanwhile. And then again, we test that against the changes you made. And did you make an improvement?
Hmm.
So again, as much as people think that AI can practice medicine, I would say that I use a lot of AI for a lot of different things in life, like smoking meat and baking and other things. And I love AI, but is the interaction with the patient and it's co-designing things with the patient and doing all of these multiple aspects of psychosocial stuff, and that each patient needs a different solution that fits within their frameworks of life.
How about telehealth? I mean, that's such a blessing for certain conditions and certain situations. But I think if you don't start out by actually seeing the person, it must be keep like playing with one hand tied behind your back as a physician because you're just not seeing the full reaction of the woman to your questions and suggestions.
Hard to say, because it's very interesting that, and again, that more comes from my executive years. We lived through
Hmm.
COVID, and it
Yes.
was fascinating to see that when we obviously went on almost full telehealth, and then we went back. So in the field of psychiatry and psychology, telehealth patients prefer it much more than in person. And in the fields of like primary care, they flipped back to in person.
Hmm.
So I actually trying to understand that puzzle. So I do say that I think that telehealth brings us an ability to reach to patients that we usually would not reach.
Hmm.
And again, going back to those high functional women, they're so busy that they're
Yeah.
probably likelier to connect with you on telehealth at the time of their convenience than walking into the office. And there may be. So anyway, it's a great question. I personally find it harder to do telehealth, but that's what I'm doing. And that's more for personal reasons because I have kids in 5 different places and I had to adjust and realize that I have to be able to practice medicine from anywhere.
Yes, and some of us who are traveling and or taking care of children or elderly parents or whatever, the convenience factor of telehealth is enormous for the patient as well. So
Right.
so it'll be interesting to see how this plays out. I think there's more and more studies about what conditions are best treated with telehealth and what maybe should not be. I see a lot of people who have primarily telehealth based practices, and I'm just wondering how does that work for you? Because sometimes you'll pick up something in an office setting that you never would on a telephone or a computer screen. So that'll be interesting.
It's also generational, I think. I
Yes,
think
yeah.
that I think we just have to deal with the reality that our kids and even us would rather be on the telehealth at the
Hmm.
convenient time for us. Then and I guess that's where the trick is. Then what can you do in addition to seeing the patient, what information you're gathering, to compensate for some of that stuff as well?
Uh-huh. So we've talked a lot about changing various things in our lifestyle that may mitigate once we've kind of sorted out the probable or potential causes of symptoms that a woman may be experiencing and habit formation. And you said you can't just tell somebody, do this, don't do that, stop doing this, do less of this, and I'll see you in a month. It's not going to work that way. So, what have you found, practically speaking, does work with trying to instill a new habit with a woman, assuming that she has agreed to it, as you said, not just us making a pronouncement, but the person buying on to that suggestion?
I mean, honestly, it depends on the habit we're trying form, and getting them to commit to what are they capable of doing within their current sort of lifestyle and structure that they have. So, and again, it's such a hard thing to say because it's so individualized, and again, that's why I say AI cannot do that because it's you sitting there and you're getting a feel of what's possible. And again,
Hmm.
you may be right or you may be wrong. But again, committing to one thing at a time, if possible. And again, listen, if you come in when your diabetes is completely out of control, right? And we're talking about basic stuff, then you may need to commit to 2 or 3 things. But then you need to have a faster follow up to see what was possible. It also depends, again, when they know their life depends on it, they're more likely to make a change. So are we talking about the soft change versus like we're going from A1C of 12 to get them somewhere under 8 fast because they'll be in the hospital and they feeling horrendous, right? So, or if they just had a fracture, I guarantee it probably will be easier to get them to take vitamin D and go to physical therapy because they know that for them to recover and get back to normal, there will be changes that will be made. So,
Mhm.
I mean, it's hard to answer, but I would say get them to articulate the change they need, get them to commit to that change and ask them what and how often and get it in writing,
In writing.
and yeah, like get in writing, like, and also have that ability to say, hey, I would like to just email me, like
Mhm.
email me with your sugars. I want to see this. I can
Your blood
tell you that,
pressure, yeah, yeah.
right?
How
Whatever you
much
pick. Hey,
exercise you did this week, yeah.
yes, the best example I have is like I had gestational diabetes like 4 times, probably five, but whatever. The time when it was picked up, and I had the doctor that would make me send my blood test. I mean, my blood sugar readings every week. And listen, and I was in an endocrinology fellowship, and
Mhm.
I was already a doctor for 10 years, right? And it made me do stuff and commit to stuff. And then the doctor ended up working for a pharmaceutical company. She went back to practice later, Cornell. But, and I was with somebody else and they were like, but you know everything. You're an endocrinology fellow. And at that time, I think I was already an endocrinologist. It was my next pregnancy. You know everything. Just take care of it. And the difference was drastic. I mean, I still did okay, but I said to myself, I needed that piece of paper at that time was an email to be sent. I think I was faxing it actually. That was, I guess,
Back in the
looking back at
days.
15 years,
Yes.
right? And I needed that. I knew everything about this. I can give lectures on gestational diabetes. I already had it. I think that was my kid number 5 when it happened. And I'm like, why am I not asked to send it? Because it took so much more effort for me to control my sugar because I wasn't accountable to anybody. And this is why we know in studies that if people live in social circles that where people exercise, everybody
Mhm.
exercises. There was a famous study, I think, from New Journal of Medicine where like they studied obesity and sort of all those different things. So again, tied in whatever change you're making to how are they making it? Is their husband or significant other is going to make it with them? Are they going to change their diet for the kids as well? Because you know what, if you do eating all the bad stuff, what are you teaching your kids? Believe me, I've done that. So my kids are healthier than me and they're the ones who are teaching me. But kind of flipping that whole framework and say, hey, they don't need simple sugars. They don't need to drink juice. Do you think you can commit to actually make their health better? Because this is what's going to happen.
I have a little anecdote about that accountability and reporting on things. For on and off during my professional life, I would have a personal trainer. And again, that would hold my feet to the fire. If our appointment was on Monday, I'd be like, oh my God, I didn't do any sit ups and push ups on Saturday. I better do them because she's going to know, on Monday that I didn't do anything. And then on Tuesday or Wednesday, I'd say, it was so good on Monday. I'm ready to do more today. So I've always suggested to my couples when I would see them for fertility, if they really were starting from zero exercise, get a trainer. It'll hold, if you can afford it, for sure.
Right.
It'll hold you accountable and you will see more changes that way. So yeah,
So I
accountability
think
is
that's a
big.
great point. And a lot of times, honestly, I end up seeing people as couples.
Yes.
And sometimes because they're both my patients, or sometimes is because I wanted to see what's happening and understand the dynamic. And then, because most people want to help their significant others, they really do, but they themselves may not understand what it means. And ultimately, whatever change we are making is good for everybody because honestly, I always say nobody would need doctors if people would eat right and exercise, manage their emotions with the right thing. And sometimes it's biofeedback, sometimes it's the breathing exercises. I mean, there's so many things, that people jump to pills but like we know that hypnosis helps with hot flashes. Does
Mhm.
anybody, does anybody know that, or things like that? Like, and if you can get that partner either, to be accountable together and,
Mhm.
or a friend. So I do think what you mentioned about the exercise and the trainer is huge. I have subscription to Peloton, to the gym, and until I got myself a trainer, I could not build my muscles for the same reason. And again, I can give lectures and all of that. We all know the right thing to do. By the way, when you lecture people, please don't lecture people because most people know what to do. It's that flip between knowing what to do and actually building into the habit is the hardest thing, which is why I think that book, Atomic Habits, is a really good book.
By
Because, I mean,
Ferris, right? The one
yeah,
by Ferris.
not
Yes.
fair. Yeah, but yeah. So it's like I'm trying to figure out how to merge some of his concepts and a few other things into what I'm practicing. That'll be the next podcast when I figure it out.
And we'll come back and talk about thyroid sometime too. So there's so much to talk about
Oh
here.
my God. The thyroid is a whole other ball game. That's probably comes as close to menopause, to this sort of how we mismanaged it over time as, I guess, the healthcare.
To be continued. We'll definitely get you back to give us your experience with that and obviously your expertise, not just your experience, but anyway. So Dr. Hanah, this has been just a wonderful time of chatting about a little bit broader concepts than what some of our other podcasts have been, but very, very important things for people to understand about managing their symptoms and managing their interactions with their healthcare providers. So thank you so much. It's been great to chat with you.
Thank you. And the only thing I want to say is the final words for all the
Sure.
women who be watching, or maybe men are watching with their women as well, is this is not the time of decline. This is the time of flourishing. This is the first time in your life, the kids are probably out of the house or getting closer to be out of the house, and you can do things that you've never thought is possible. So look at this time and realize that you can build your strength, you can build your cognition, you can build so many things around you, and you can thrive, and you can be 80 and 90 and you can be skiing and doing the best things that you've never imagined you can do.
Thank you for that message. That's something we need to keep hearing over and over again. And my listeners and watchers, if you appreciate this kind of information, please like and subscribe and tell your friends. It'll help to get this wonderful information out to more people. Thanks, and we'll see you again soon.
Thank you.
If this episode spoke to you, please share it with a friend ready to take charge of her health. And please leave a review. It helps more people to find us.